This is Neuromuscular and Musculoskeletal Disorders Part 3. So moving on to cerebral palsy. This is a group of non-specific symptoms. So it's not, the cause can be different, but it is a problem of motor and balance. So it's a problem where the nerves, the motor nerves, have been damaged. This is lifelong. You do not get over it, but it also is not progressive. It doesn't worsen. So high incidence of premature and low birth weight babies have cerebral palsy. And as I said, it's permanent but non-progressive. So the signs are motor impairment. So abnormal motor patterns, spasticity is kind of stiff movements. They can be weak, ataxic. You've probably seen people who toe walk, or they use so much energy walking or moving. It's just a lot harder for them. So it is a problem, a neuro problem of those motor neurons. So CP by itself does not necessarily have impaired cognition, but it can have mental impairments with it. It can have seizures, growth problems, vision and hearing problems, sensation and perception problems, and hydrocephalus, but those don't necessarily have to go along with it. So we usually divide up CP by types. Spastic, they are hypertonic, meaning stiff. Their movements are very jerky, and that's the most common type. And then dyskinetic, or non-spastic, they have involuntary, uncontrollable movements that really are not predictable. And it's especially when they go to move, muscles start twitching as they try to control them to move. Ataxic, this is just gait problems, unsteady gait, decreased coordination. That's not the most common type, and then there's lots that are a mixture of all of those. So what are signs of CP? A baby who is delayed in their gross motor skills. We should be watching. A baby who's just really irritable. They stand or walk on their toes. Feeding difficulties. If their muscle tone is off, either high or low. And I'd say one of the real signs we look for, if you take an infant and hold them up under their arms, their legs should hang down. In CP, their legs will cross, so they say scissoring of the legs. Abnormal posture and reflexes. So these kids often will keep those neonatal reflexes beyond the normal range of when they should. And persistent clenched fists, right? Babies are born with their fists tight, but they should start using their hands, and so these kids don't. Those fists stay tight. Our therapeutic goals with this are to promote mobility and communication and self-help skills. We really want to promote optimal appearance and integration of motor functions. Help them to look and move as normally as we possibly can. If there are other defects along with it, correct those. We want to give them appropriate educational opportunities, but they're going to have to be adapted. They're not going to be able to do what other kids can do. They're not going to be able to hold a pencil the same. They might need some sort of thing where they can talk into a computer and it types for them, things like that. And then we want to promote socialization experiences with unaffected children so they can see what is normal. And in our area, Break the Barriers is a great company that does that. They do gymnastics with kids who are able and disabled. Intervention, sometimes surgery to correct contractures if there's tendons that have shrunk or some other sort of deformity, braces and supportive devices. We do have some medications because a lot of times they have muscle spasms. It can be very painful. So those antispasmodics, baclofen and Botox, both can help the muscle to not spasm. Baclofen can be given orally. It can also be put under the skin in a pump that continually delivers a small amount. Analgesics, we said a lot of these kids have seizures, so anti-epileptic medicine too. Involve the family and listen to them. They know what's normal for this child, and they can tell us when the child's not acting normal. These kids need frequent rest periods. To move takes more energy for them. And then they still need to be children, though. So recreational outlets, but we've got to make sure they've got the protective equipment that will work for them. Support the whole family. This is hard. They're raising a child that has more needs than usual. Raising children is hard. Raising children with special needs is harder. So support the family and support the hospitalized child. Usually they're not admitted for CP. They're admitted for some other reason, but we need to keep in mind their CP as well. And mobility, helping these kids be mobile. Right? Sometimes it takes being pretty creative. Feeding a child with CP, they may need help learning how to swallow. Okay, slipped capital femoral epiphysis. So this is that top of the femur at the epiphysis kind of slips apart. This usually happens during that rapid growth, that pre-puberty growth spurt between 9 and 16 years. The femoral neck, it slips, deforming the head, and it pulls on the blood vessels. So this is our concern, is if we can get it back normal, everything will heal. But if not, you can have some permanent damage done. So these kids are going to be on bed rest and traction, and then have surgery to pin it in place so that it stays where it should and grows normally. And as long as we can prevent damage, they do okay. Legg-Calve-Perthes disease. This is self-limiting, idiopathic, usually boys 4 to 8 years old. This is avascular aseptic necrosis of the femoral head. So again, we get this issue of the femoral head. This one, it flattens. Then it will reabsorb and make new bone. So we want to rest it, non-weight bearing. They might use traction. Usually doesn't need surgery though. Not like the slipped epiphyseal does. But we want to rest it and hopefully let it heal on its own. Some doctors say this probably is related to overuse injuries, so the same thing over and over, the kid who's playing soccer or doing something where they're doing the same movement. Kyphosis, lordosis, scoliosis. Scoliosis is kind of a twisting of the spine. So you get these unequal shoulders, if it's thoracic, unequal hips, if it's a little lower down lumbar, but it's kind of a sideways twisting. Lordosis, it's kyphosis, they call that dowager's hump, right? The back kind of has that hump up here, and lordosis is sway back. So scoliosis, they measure it in degrees, how much the curve to the spine is, and if it's more than 10 degrees, then we call that some mild scoliosis. This often is congenital. It does run in the families, can be with other disorders. Kids who are not upright are at high risk as well. Idiopathic, we don't know why it happens. Neuromuscular or congenital, then those would be the reasons why. They can try and brace it, especially if it's before that puberty growth spurt, they may try and brace it. Otherwise, they'll do surgery. And you can see how bent this girl's back is. This is when you have them bend down, you see that crooked spine, and it makes it uneven here. Here's the braces they might try, and then here's the surgery. So here's the spine pre-surgery. They put in these rods, right? And here's the same thing, showing you rods, and just pull the spine straight. So fractures, these are common in children, right? The good thing is kids heal fast. We don't see many fractures in infants, partly because their bones are softer. They're not really fully ossified yet. Usually when they do get fractures, it's motor vehicle accidents, but you should always be suspicious of abuse when a child has a fracture that doesn't have a clear reason, like a motor vehicle crash. The problem is the growth plate is the softest, easiest place for a fracture to happen, and then it can interfere with growth. The clavicle is actually the most commonly broken bone in childhood, and that usually happens sports and bike injuries. So what do you see? Some generalized swelling, pain and tenderness. It looks deformed. They won't use it. You can also have bruising or severe muscular rigidity. Crepitus is the sound of bone grinding on bone. And this, I said, we're worried about it going through the growth plate, right? Here's our growth plate. Easy for it to break there, or sometimes it's just partial through the growth plate. This, just some damage happened there. Types of fractures kids get. Think of their bones as being softer, so you get things like this plastic deformation or green stick. An adult's bone will just crack and snap in half, where a child you often get this, and then as it comes back you might get this buckle. But we can get the complete, just like with an adult. Sprains and strains. Sprains happen fast, strains happen from repetitive movement, but either way we've damaged ligaments, stretched them out. The child will say the joint feels loose, and the treatment is RICE, rest, ice, compression, elevation. So rest it, wrap it, not so tight that you cut off blood supply though, right? Put ice over it, 20 to 30 minutes on, an hour off, and elevate it above the heart. So overuse syndromes, repetitive motions over and over and over on the soft tissue. This is what we usually call strains rather than sprains. It's painful, it happens slowly, often from organized sports because they're doing the same thing. So treat this with ice and NSAIDs to bring down the swelling, limit the use. And when they do return to the sport, encourage a nice slow warm up, that they're using the proper safety equipment, that they take a couple days off from training and competing each week, and take a little bit of time off from the sport every year, a couple of months off. Radial head subluxation. This is a partial dislocation of the elbow. This they often call nursemaid's elbow, because the nurse, right, the old term for a nanny, grabbed the kid by the hand and yanked. It pulls the elbow out. It's usually kids, this is younger than 5. I was going to say younger than 4. So usually it's little kids, and it partially dislocates that elbow. The physician takes it, aligns it, and snaps it right back into place. And once it's in, it's fine. It's not painful any longer.